Good morning, everyone, and welcome to our virtual town hall. This is a partnership with several of our local chambers of commerce and business organizations. We'll recognize them in just a moment, but first, a little housekeeping. We're using Skype broadcast for this town hall, and as you can see on the screen here, some instructions on how to successfully participate today. You can hear us, but we cannot hear you. This is interactive, however, and we do want to hear from you. You can send us questions throughout the presentation, and then we will have a live Q&A at the end. But don't wait for that to start sending in your questions, and you can do that either on the right of your screen of where the slide is presented or underneath, depending on your display and your device. This is also closed captioned. You can click on that icon on the lower right-hand corner if you want to follow along through closed captioning. If for some reason the slides become paused or you can't hear the audio, you may have accidentally paused it at the lower left-hand corner. So please be mindful of that. And we will have a presentation available afterwards to share. So with that, let's get started. Again, my name is Don Stanziano. I'm the Chief Marketing Officer at Geisinger. And Geisinger is pleased to present this virtual town hall today in partnership with our local business community. I'd like to take a moment to recognize all of our partners today: the Chamber of Business and Industry in Center County, the Greater Wilkes-Barre Chamber of Commerce, the Harrisburg Regional Chamber and CREDC, the Juniata River Valley Chamber of Commerce, the Carlisle Area Chamber of Commerce, the Columbia Montour Chamber of Commerce, the Greater Hazleton Chamber of Commerce, the Greater Scranton Chamber of Commerce, the Greater Susquehanna Valley Chamber of Commerce, the Schuylkill Chamber of Commerce, Williamsport-Lycoming Chamber of Commerce, Clinton County Economic Partnership, Penns Northeast, and Wyoming County Chamber of Commerce. So we thank all of you very much. Our presenters today are Dr. Jae-Won Ryu, our President and CEO at Geisinger, Dr. Ed Hartle, our Chief Medical Officer, and Allison Hess, our Vice President of Health and Wellness. And we'll kick it off with Dr. Ryu. Thank you so much.
Thank you, Don, and thank you to everybody joining us today. We've been doing or using these virtual town hall forums to try to get information out to the communities and to maintain the links with all of the partners that we have, both internally and externally. And so your participation means a lot to us, and we appreciate the partnership. Next slide. We've been starting really with the national outlook, and I think most of us have seen some semblance of this kind of map. It's a heat map across the country, and I think a few things to call out. One, I think as every one of us is aware, by virtue of just following the media coverage on the COVID pandemic, we know that really April was the month where the country saw a massive climb in the number of cases and the number of deaths. It started back in March, probably the latter half of March, but the real steep part of the climb has happened in April. And the other thing on a national level, I think we're all aware that there's been a little bit of a plateauing or a leveling off potentially of the rate of climb of the cases, which is different than the case numbers itself. It suggests that the pace of it might be slowing down, but every day there continues to still be new cases. And I think there's a word of caution we've been encouraging, which is that a lot of the national numbers and trends are driven off of the New York metropolitan market because it comprises such a big part of the volume. And so I think there's a little bit of grain of salt you have to take with looking at these big national numbers, because what you may end up looking at from a trend perspective is just the impact of New York kind of dominating. So any kind of leveling off may simply be reflecting the New York metropolitan market leveling off. And so to understand more specifically at our level, next slide, we've taken it to the state level, and a heat map here based on zip code. You can see darker blue indicates more COVID activity. Lighter shades represents less COVID activity. I think the same punchline that April represented the massive growth in both the number of cases and the number of deaths, I think that continues to hold. across the state, you see that there are certain hotspots. I think if you look at the areas that we at Geisinger serve, the Luzerne, Lackawanna counties up in the Northeast seem to be where we've had the largest number of cases. And I think statewide, it's probably the second hotspot after some of the Philadelphia and surrounding county areas. And I think that makes sense given that's where the state has gone ahead and put one of its testing sites. I think they're reflecting where the activity is and kind of mapping accordingly. What we've also seen in our prediction models is sort of a phased peak scenario, meaning different areas, different counties are anticipated to hit their peak volumes at different stages. And originally, I think some of our projections had projected that we would be seeing earlier and higher peaks. At this point, I think we're seeing the latest projections suggest that the peaks will be lower. That's a great thing. And that they'll be pushed further out in time, well into the summer months, for some of these other counties that we serve. Northeast, it seems like things have kind of plateaued, but we're obviously keeping a keen eye on that, because what we've also learned about the virus is that all it takes is one outbreak, whether it's a nursing home, a meatpacking plant, some other environment, one outbreak ends up leading to a whole slew of downstream activity and cases in the community. And so I think the punchline here that we've been reinforcing both internally and externally is it's not time to let up. That being said, we think there's a safe and effective way to reintroduce and phase in activity within society and within the health systems. But those precautions, whether they're distancing or masking, hand hygiene, educating folks, that will be critically important in any kind of phased recovery plan. Next slide, Keith. These are some of our numbers specific at Geisinger. We've tested a little over 15,000 people at this point. I think one of the big advantages we've had, we were one of the first, in fact, one of the first 2 sites in Pennsylvania that were able to do our own testing. And that allowed us to get faster turnaround times as far as the results. And of course, when we're able to result these faster, it means we're using less PPE because people are able to be ruled out who are negative, and those who are ruling in are more quickly able to take the right precautions and prevent infecting others. And so that early testing capability was very, very instrumental to our efforts. Of those that we test, we have seen pretty consistently about 15% or so of the people end up testing positive. And what we've also seen is that about 15% of those who test positive end up requiring hospitalization. And then what we've also seen is about 20 to 25% of those who require hospitalization require ICU level care. And so if you're really looking at 15% of the 15%, is what you're looking at as far as those requiring hospitalization, and it's 25% of those that are in the ICU. There's still a lot of folks making recoveries. I think there's some good news here. We continue to discharge people and downgrade them from the ICU to regular hospital beds, get people off of ventilators, send people home who are positive but who are doing just fine, and we continue to monitor them virtually. I think there's a lot of folks making great recoveries, but at the same time, this is a very serious virus. I think we got to be careful because it does lead to death, and we've seen 71 of those at this point as well. So it's a mixed picture. There's a lot of good things happening with the care, but there's also a very serious virus that we're facing, and so the precautions are going to be important for months to come. Next slide.
Hey, Dr. Rue?
Yeah.
I just want to point out on this last slide for the audience that the map is not reflective of the numbers that you just ran through. Those red dots are reflective of Geisinger's facilities around the communities.
Ah,
As I was listening to you, I realized that might be confusing for our
that's
audience.
great clarification, Don. The map on the left, not a heat map of the cases. The red dots simply represent where we have our facilities and clinics, so that you can overlay that against the heat map, which is on the previous slide, right there. So it gives you a sense of where the activity is versus where we are. Next slide, Keith, and you can go to that one. Yeah. So at the same time, we've been planning for a surge. Gosh, we've had a team going back to January working on potential surge capacity planning. That's beds, ventilators, staff, testing, equipment, supplies. It's all of the above, and layering in the geographic component. As I referenced earlier, our predictive models and data analytics team have seen the earlier peaks come in the Northeast, but all the other areas that we serve, we think there's a cascade and a phase of 2 or 3 or even 4 weeks behind that, different areas seeing their own quote unquote peak, which may not be as high, but still a steady climb in cases as each area hits their own separate peaks. And if you really map this out across all the areas that we serve, some areas it might mean that that peak may be lower than what we had previously projected. That's what we're thinking now, but it may be hitting well into August, for example. And so I think that phase nature and the very local nature of how this thing is playing out, I think are important points to continue to keep in mind, meaning, where we are in Lewistown or State College, it's a very different picture than what Lackawanna or Luzerne County might look like, just to illustrate the point. Next slide. This gets to the point I was talking about earlier. I mean, we started tracking and counting because there's a lot of recovery stories. And I think sometimes that gets lost in the mix because the media and even the healthcare systems, we tend to focus on how many are admitted, how many are in the ICU, how many have died. But really, we know that every day a lot of folks are recovering and heading home as well. This is a picture of 3 of our ICU nurses up at GCMC, and you can see they're holding up a 1, a 2, and a 3, and those are just that day the folks they were able to wean off of a ventilator and get them out of the ICU and into a normal bed environment, which suggests that those patients are well on their way to making a recovery. And then on the left-hand side, you can see some whiteboards that we have at each of our campuses that talk about those recoveries, and a lot of good stories. On one of our campuses up at GWV just the other day, there was a celebration because it was the 100th patient that we had been able to successfully discharge because of the recovery that they had made. So a lot of neat stories. Next slide. We've also really launched in earnest this telemedicine program to be able to still maintain care connections with our patients and their families, and be able to take care of their care needs virtually. And we had some of this activity, believe it or not, even prior to COVID, specifically in teledermatology, telepsychiatry. We have an eICU program that's pretty robust, and in fact, we provide the service to many other health systems as well. But telemedicine has taken off as a result of COVID across all of our departments. And it's not every single visit that we're able to do virtually, because sometimes you have to lay hands on being able to examine the patient, listen to their heart, listen to their lungs. So if those things, depending on the care needs, some still require the in-person visit, but telemedicine has been something that we've seen resounding success. Both our providers and our patients, the feedback has been phenomenal. And so it's been a neat way for us to continue to manage, whether it's the diabetics or the folks with congestive heart failure, and making sure that their needs are met during this time. Next slide. The other thing I should say, and this gives you a graphic depiction of week by week what that telemedicine growth has looked like, as well as some pictures of some neat ways that we're creatively solving for those needs. And it's not just the virtual visits, but it's also using devices to connect to patients in rooms where they may be COVID positive, but to limit the use of PPE, we've been able to use video capabilities to continue to communicate and interact with those patients. At the same time that obviously when we need to go in for actual care and laying hands and examining the patient, we're still doing that and going into the rooms. I think the picture is illustrative because one of our campuses, it turns out, this is the one up at Jersey Shore, turns out that we have wooden doors, and so the visibility isn't as good as we would like for the COVID patients, and so the telemedicine gives us that additional visibility. So it's not always just these virtual visits. I think telemedicine is here to stay, and I think even on the other side of COVID, it's going to be a key ingredient in our delivery model. I know that some others are already anticipating that this would scale down or this would, disappear, or they're not sure they can sustain it. I think this is one where we believe it's absolutely worth sustaining. If you see some of the feedback we've gotten from the patients and their families, we know this has got to be a key element of how we deliver care in the future. It also gets to the cost of care because to the extent we're using these visits and potentially avoiding in-person or ER types of visits, we know that there's an opportunity there as well. Next slide. Another program that we've always had that has just kind of kicked into a different gear as a result of COVID has been our mail order pharmacy. So this is any chronic maintenance medication. We make this available for patients to get the medication delivered to their doorstep, as opposed to them having to go to a pharmacy and pick up the refills. This is, at no charge to the member, and the co-pays that they have in this program are substantially less than what they would have in a traditional, if they showed up at a retail pharmacy. We're able to pass a lot of the savings back to the patients by way of cheaper co-pays, no additional cost as far as the delivery. And I would argue, as a physician and as a clinically minded oriented organization, we would say the other neat thing is we have found that patients are 37% more likely to take their medications if they're on this program. And that means that there are 37% more diabetics, more hypertensives, more patients with congestive heart failure that are actually taking the medications they need, which of course has a downstream impact on the total cost of care for their diseases and for their conditions. And so this has been a big winner across the board. You can see year over year, we've seen significant increases in the popularity and the uptake of the program. And we see that continuing to grow, especially during this time of COVID. Next slide. This is one where we've just been overwhelmed with the outpouring of support and donations and generosity from our communities. Folks and organizations, both big and small, have really been abundantly generous during this time. And we've gotten at this point over 328,000 of monetary support across 427 donors. That's helped us purchase some of the PPE, the supplies, the equipment, the lab testing materials. Obviously, COVID has a significant financial impact on all health systems. Every little bit does help, and I think it helps not just monetarily, but also I think it's an encouragement and an uplifting kind of thing for our folks to look at as inspiration as they're tackling and fighting the COVID pandemic. We have some icons of different companies that have stepped forward with these donations: Giant, First Quality, and Service First. Next slide. We've also gotten, next slide, Keith.
Oh, sorry.
We've also gotten in-kind donations of supplies and equipment, and these are some of the organizations that have stepped forward with that on the left-hand side. You can see that it's a mix of both local as well as some national, and each of these national companies also have a local flavor to them as far as connections to various employees of ours or or leaders at those various organizations that happen to have roots in our community. There's a whole host of really good things happening on this front. Next slide. So I'm going to turn it over to Dr. Ed Hartle. He's our System Chief Medical Officer, and really has been running point on all of our preparedness and response efforts related to COVID. I think we have some clinical information, because I know we get a lot of questions and curiosity around that. Ed?
Thanks, Dr. Brewer. Thank you all for being on the call, and in particular for the chambers. Thank you for your service to our communities. So next slide, Keith. As Dr. Brewer said, we have a world-class laboratory, and it's really helped to facilitate us to be able to address the needs of our patients in regards to COVID testing. Our testing conforms to that of the CDC and the FDA criteria, and we've been able to, within our own walls, so to speak, do all of our testing for our patient population, as well as patients and employees, I should say, as well as extending beyond that to our community partners, including other health systems, our skilled nursing facilities, and our first responders. So I think really trying to provide an overall care, so to speak, for our the areas that we serve. As Dr. Ruth said, we were one of the first few providers within the state, actually one of the first two, and now one of the first three, that has the ability to do our own testing internally. And in regards to that, we're able to do same-day testing for individuals who conform to the CDC criteria, which we'll go into a little bit further on the next slide, as well as have really rapid turnaround of results. So one of our assays, we have about a 1 hour turnaround from when the time the sample hits our laboratory to the result occurs. So as I mentioned, our criteria is based on that from the CDC guidelines, which has been recently updated by the CDC as well. For a variety of reasons, both the CDC and infectious disease experts have defined that individuals who do not have symptoms shouldn't be tested. However, those individuals who do have symptoms, such as cough, shortness of breath, or fever, and most recently for another constellation of symptoms, including chills, muscle pain, headache, sore throat, or loss of taste or smell, and has had one of three criteria. Either they've had a close contact with a suspected or laboratory confirmed COVID-19 patient within the previous 14 days, or they're an individual with increased risk if COVID-19 should occur, as well as having the symptoms, or a healthcare worker with symptoms. All of those comply with the CDC guidelines for testing, and they're the individuals that we do test internally, and as I said, in a rapid time frame.
There are some categories of folks who may not have the symptoms, where the criteria has kind of expanded to accommodate testing for those pockets of people. This is a quickly evolving space, both from the CDC and from the FDA, which are really the two regulatory bodies that have oversight over this area. But as we incorporate other categories of people, we of course update our guidelines and the criteria in conjunction with working with the appropriate regulatory authorities. But I think the punchline, because we get asked this question a lot, is indiscriminate across the board testing of people who don't have symptoms is not currently guideline approved. And unless you fit into one of the other exception categories, which is a evolving and steadily growing list, then testing would not be scientifically appropriate. And so we've been trying to adhere and keep pace and really be ahead of these guidelines, but we thought it's important to give you that information.
That's great points. Thanks for the clarification there, Dr. Rue. Keith, next slide. We've also been very actively involved in terms of the data and in regards to clinical trials or clinical protocols, and have been very aggressive internally about developing our own protocols, both from a inpatient as well as outpatient, and actually providing guidance to our skilled nursing facilities for protocols related to the COVID patient as well. Part of that, or some of the examples of that, are the data in regards to hydroxychloroquine and azithromycin, which initially on was advocated as a combination therapy, or more recent data would suggest that they should not be used together and that it should be hydroxychloroquine alone because of the cardiac toxicity seen when both agents were being used together. We've been involved with clinical trials, including convalescent plasma, and we are part of the Mayo Clinic Expanded Access Protocol. To date, we've had 65 patients that have been treated with convalescent plasma, but I do want to emphasize that the protocol has defined criteria and prioritization for who is a potential recipient. So it's not just every patient that potentially is a candidate to receive that convalescent plasma. We were also involved with a trial on an IL-6 inhibitor from a company known as Regeneron. That trial, that agent, I should say, was used predominantly in individuals which had more serious disease presence in what we call a cytokine release. And it had some promising results with that, waiting for the data from the trial itself. We had been able to give remdesivir, which is an antiviral, but most recently the FDA is incorporated under what's called the EUA, or Emergency Use Authorization, and the FDA is making the determination who gets the availability of remdesivir to be able to be given, and we expect in the future that will be part of that, et cetera, as well. We have a research oversight committee that continues to meet weekly to evaluate and make adjustments to our protocols, and frequently do that as well. A frequent question we get asked about is antibody testing. And just for a few points of clarification in that regard, antibody testing has been, of course, widely present within the news. In part because of the desire to understand who may have been infected. Part of the issue, however, is that many of the assays that were developed had a very low sensitivity and a low specificity, meaning that a patient could have had COVID and it would not be picked up, or they may have had a different type of virus and it would show up as potentially being as COVID. Because of that, the FDA has been very restrictive about allowing this to go forward, and only most recently has given EUA, or Emergency Use Authorization, to 3 commercial labs, and now up to 17 different assays for potential consideration. We have gone through the process as the FDA has required and recommended to review assays to determine how viable and how reliable they are to be able to be used. And we have selected out a assay to use for that, and expect to have that up and running by the end of May. Part of the issue of being able to run it before that is a lack of reagent in order to be able to run the test. I really would like to emphasize, though, that the antibody testing is not for diagnosis of COVID. And at this point, there is no available assay that also confers immunity to COVID. It is strictly at this point in time an assay that can help to confer whether a previous or a past infection with COVID had occurred.
So just, there's a lot on the slide. I think a lot of technical information, a lot of names that, I have trouble pronouncing. I think the punchline on this is a very quickly emerging area of science, both from a testing standpoint and a treatment standpoint. I think the entire industry is learning a lot. There's some earlier evidence from countries that went before us on their surge. And so a lot of the medications that you see are based on past history with certain kinds of diseases that were relatively similar, or past history with other countries that have gone before us. I think the key takeaway points here are we're keeping up with the science, and in fact, I would say we're keenly involved in some of these clinical trials. And I think from our area, I don't know other systems that have been as involved with some of these clinical trials. So that's a great thing, because as an example, sarilumab is a medication that at other sites in our community, non-Geisinger, you can't access that drug because it's only accessible through a clinical trial, and we are one of the participant sites along with several others across the country. In the case of convalescent plasma administration, we're one of the few sites that have that in our areas as well, and we do that in partnership with the Mayo Expanded Access Protocol. And then the other is across the industry, there's a lot of potential solutions being thrown at the virus. That's a good thing because I think people are acknowledging and really seeing what might work. But it also is the downside of that is there's a lot that's unknown. And I think we have to still be careful to maintain the discipline around accuracy and science. And that's been the approach that we've taken, both from a medication standpoint and an antibody testing. Good example is Dr. Hartle mentioned the hydroxychloroquine and azithromycin. If we rewound the tape 6 weeks ago, there were a lot of people rushing to get those two things across the board to a lot of people. Well, it turns out now with the evidence that we have as an industry that that combination has been shown to lead to heart arrhythmias. These are not harmless medications. And so we got to still be sure that we're adhering to the science. And as these things are becoming more and more known, we do a pretty rapid incorporation into our protocols and into the testing suite of services that we've put in place.
Thank you so much, Dr. Rue. And now, next slide, I'd like to turn it over to Allison Hess, who, as mentioned, is our Vice President of Health and Wellness and has been a key person in terms of how we've dealt with and have addressed the concerns of our employees.
Thank you, Dr. Hartle. And again, want to extend my appreciation to the chambers that have joined and are working so diligently with our communities as well. Next slide, Keith. Like all of you at Geisinger, we're focused on protecting the health of our employees, our patients, and our communities. And we've implemented programs and policies over the last few weeks to really target our COVID response from the start of this journey. And we continue to modify and adjust those as we navigate through this. I think one thing, as Dr. Rue highlighted earlier, this is an ever-changing and ever-evolving experience. And so really making sure that we have the most up-to-date information and that we're able to navigate through that appropriately is really important to us. What we've listed here are just some general guidelines that we've implemented across our employee population. So as Dr. Hartle mentioned, the screening symptoms, we are screening all employees, patients, and visitors, but primarily employees before they come to work must complete a digital screening. And if they do have symptoms, we have appropriate a course of action for them where they engage with employee health and get tested right away. We are masking. We are getting ready to implement a temperature check daily across the organization. We're doing it in some places currently, but we'll continue to evolve that across the organization. And we will continue with masking, quarantining, sending for testing if any symptoms as we continue through the next couple weeks. We have some employer recommendations up here as well. But again, we have a website at the bottom for the CDC and Department of Health. They have been great resources for us through this process. And there's specifically a community reopening guidance link that's available through the CDC that is very helpful as well. So these are some of the things: screening employees, staggering lunch breaks, avoiding meetings, continuing to social distance, educate, provide signage, avoid non-essential travel, work from home where possible, and then continue to follow those guidelines is really important. Next slide, please. As Pennsylvania has started to roll out a process for reopening, we wanted to put some information up here. I'm sure many of you are aware of this, as it's been bucketed out into a couple different phases. We have the red phase, the yellow phase, and the green phase. And really what's important to remember, red phase is our current state, and the yellow phase is where we begin to power back on. But as Dr. Rue mentioned, we really do need to continue to keep a close eye and be diligent in a lot of the things that we've put in place now. So the social distancing and masking and really making sure that we're being mindful of the concerns with the yellow phase. And then the green phase would be where there'd be even less restrictions, but again, still very important to monitor public health indicators and really pay attention as we continue to move forward. We are in the process of deploying a back to work resource guide and toolkit for our employers in our communities, as well as community members as they're trying to navigate through this time. And that toolkit will contain signage as well as other appropriate cleaning and disinfecting guidelines. It'll lead to connections for community-based resources. It'll have tips for telework and best practices for virtual meetings, recommendations for healthy work from home routines, educations to minimize exposure in the workplace and promote good hygiene, as well as printable digital materials and other resources available. So we've really taken a lot of the work that we've done here at Geisinger and tried to package that in a way that we can disseminate to help support our community partners and our employers.
Yeah, Allison, I think this slide, I think the key is we firmly believe that there are safe ways to reopen and reintroduce segments of society and functions of businesses. It's all in the how. And how you do it is really where the discussion needs to be and where the attention needs to focus, because there are good ways to do it, but you got to be really mindful of how you go about doing it. And I know that a lot of, at least our clients on the GHP side, have really tapped into our expertise around asking us questions around what are some tips and tricks that they could use, whether it's in terms of screening their employees or rejiggering how they do manufacturing work and some of the processes that they use, those kinds of things, especially some of these businesses that aren't at the size and scale where they have their own employee health department. I think we've been very fortunate and certainly willing as a partner to step in and help give some of that expertise.
Yeah, absolutely. Next slide, please. Some of the other things that we've done, we've also really worked very quickly to stand up a program that was already planned. It was planned for an October release, but dedicated the resources to get this up much sooner. We deployed this the end of March, and this is a website called Neighborly. It's done in conjunction with our community partners and was really developed very closely with many community organizations that we work with. This is right now a resource where anyone in the community can go in and search for any type of social service need like food, healthcare options. They can look for housing or transportation solutions. So it's really an all-inclusive tool for them to be able to find right in their community by zip code what services are available. Right now, we have 8,397 resources available that are loaded, and almost 7,000 of those resources are local resources. So the largest majority are local. We have a team that's dedicated to making sure that those resources are current and updated and have capacity as we're putting those out for our community members to take advantage of. To date, we still see about 53% of those searches related to food, and there's about 17% related to housing. So definitely using this to also understand where we can implement other services across the footprint to try and help. We mentioned the back to work resources, but we've also enhanced transportation services. We've had an increased need across our organization and our communities to provide transportation from the hospital, especially when transportation companies were limiting their service, or there was limited opportunity for friends and family to transport their loved ones if needed. And so we did implement a transportation service program for discharge, and to date we've discharged over 31 patients from the hospital who were unable to retain transportation. And we also, in our pilot program, have provided over 19,000 rides to Geisinger facilities or other community-based organizations or healthcare organizations for services, including medical, as well as food pickup or prescription services. We have also stood up an emergency food distribution program. This is available again across the coverage area, and to date, we've provided over 300 boxes of food to over 400 individuals within the community, feeding families. And so it's really important to make sure that we do have access for individuals who are in need, and we've partnered with other local food pantries as well to offer them support. So enhanced our emergency food distribution program as well through this process. We've provided virtual classes. So many of our community-based programs that we were completing in local community areas, we transitioned to virtual. We have provided over 50 virtual classes to date with well over 300 participants in those programs. So really trying to maintain, it goes back to Dr. Rue's point about telemedicine, kind of this virtual contact. We will continue to retain and build out those services moving forward because we really find that they bring value, not just in the community setting, but also for our employer groups as well. So we'll continue to build those out. And then lastly, we have provided care packages for our COVID positive patients to make sure that we're getting them the important materials that they need and the information that they need, and that they have access to all of these other programs that we mentioned earlier.
I think a lot of these programs, if you just take a step back, the reason why it makes sense for us, and maybe in some ways how we're different, is that we approach this not just as a clinical enterprise side of our organization that's able to bring all of the clinical capabilities, whether it's the testing or the treatment, or obviously the folks hospitalized in our sites that Dr. Hartle went over, but also the folks getting discharged at home, continuing to be able to monitor them, maintain ties with them, monitor their symptoms in case they need to come in and be evaluated for potential hospitalization. And then for the rest of our patient base, obviously maintaining those services. So there's this whole clinical component, but then it's also married up with the fact that we have contacts and connections to these organizations in the community and to the employers through our health plan side, our health insurance side, and bringing those two capabilities together provides a neat opportunity to really partner, but do so in a way that betters the community, because we're able to flatten the curve and mitigate against the pandemic itself. So I think they've been sort of two levers that have been very convenient in terms of finding ways to partner, whether it's bringing programs like this that you can really only do if you have both of those relationships working in an integrated way, which is a big part of what we do.
Absolutely.
So with that, I think we're ready for Q&A, and we've gotten a lot of questions from you. So thank you all very much. A lot of clinical questions from the front end, but first I'd like to go back to you, Allison. There were a lot of questions asking about the toolkit you referenced and when it would be available and how they can access it.
Yeah, so we'll push out that information. We're hoping that that's actually available the end of this week. We're working on the final stages of that. And there will be multiple ways that we'll communicate that, but we will have information on the Geisinger website. We'll also have information on the health plan site, and we'll be doing some direct communication as well. So we'll make sure that that gets pushed out. And if we have a list of individuals who attended this, we can also push it out there. So that should be coming out the end of this week.
Great, great. Staying on that topic, because there's a lot of questions asking for very specific practical information for business owners, asking them to open their business. And maybe we can't give that direct advice here, but just in general, some of the things that were asked, cubicle wall height or cleaning protocols for their workspaces. Can we address those types of questions here? Do we have a resource we can refer folks to?
Yeah, so we don't necessarily need to go into the level of detail here, but what I can assure you is in that toolkit, we have focused a lot of time on what are the recommended cleaning supplies, workspace type of enhancements, and a lot of other items that I think will address those types of questions, Don. But if there's additional questions outside of what is able to be found within those resources, we're here to help. And so certainly please feel free to reach out. There'll be contact information on there as well, and we can get people pointed in the right direction for sure.
Great, great. There was also some questions regarding temperature checks of staff and guidance on that. And I don't know if that's something we can address here on the call, or if that's something
Yeah.
we should follow up with.
No, we can certainly address that. I mean, we are in the process of implementing that across the organization. We do have it happening in some places currently. It's really a supply issue right now, with trying to get as many thermometers as we need to be able to do it. So once we get those in, we will be implementing that across the organization. That will continue to be part of the daily screening process that we do.
For Geisinger, you're talking.
Correct.
I think the question was more if an employer wanted to offer to their employees.
Yeah, we
what
can.
guidance can we provide there?
Yeah, we absolutely. So as part of that package, we're also talking about what type of screening questions should be asked daily, how to implement temperature checks. So all of those things in the process, recommendations for how to do that. We really want to work with each employer, understand what their current process is. Do they have people coming in through a centralized or decentralized location? We'll help them navigate through each of those pieces, because those are all experiences we've had here. Not all of our campuses are the same. And so we've had the opportunity to be able to try a couple different processes, and we feel like we'll be able to use that experience to help employers navigate through that.
Yeah, we've had a wealth of experience on this, because I think early on, gosh, it was probably even late March, we went to universal masking on all of our campuses, and also universal screening, including temperature checks for patients entering each of our sites. And then we had screening for all of our employees, and then a phased manner incorporating the temperature checks even for our employees. So we've been doing the screening thing for a while, including temperature checks on the patient component, and then phasing that in on the employee component. But I think it gets to Allison's point. What we discovered was each place, there's a slightly different layout and design. You know, are there multiple sites of where you can enter the building? What's the workflow that makes sense? I think it requires that really getting down to the local detail, and working in partnership to get to the right workflow. Sorry, Dave.
No, all I was going to echo is two things. You want to be able to do that screening, but you don't want to do it from the perspective that you're now backing people up and you have a congregation of individuals to try to work through. And the other thing is on the slides, the same questions that we ask in regards to the screening includes the CDC guidelines in regards to temperature, and that's 100.4 or above.
Yeah, that's a good point on the line, because I think some of the early learning was screening's great, that's exactly right, but you got to be really thoughtful how you do it, because the last thing you want to do is create a line at the door, and now you've kind of done away with distancing. So this ends up being a balancing of how do you solve for both at the same time.
Yeah, I think there's a lot of logistics to this, and that's what we want to, again, we took as much as we could and package that up, but understand that there will need to be probably additional communications, again, to that local individualized need.
Yeah, the folks are even asking how to source the thermometers. They're not easy to find, apparently.
They are not easy to find. We're still working through that as well on our end.
There are a few different options. There's the infrared, what I'll call the zappers, which are probably faster and easier for screening purposes. And then there's more of the medical grade stuff with the disposable ear tips. I think the latter is tougher to get a hold of. The former, you lose a little bit of accuracy, but it's probably still good enough. And I think those seem to be a little more accessible.
And the no-touch option is probably a safer option to go with the infrared, right?
The zapper?
Yeah.
Yeah.
But even the infrared, that's where we're hung up right now, is getting this shipment in. And to the point that Dr. Rue mentioned, the other ones where the tympanic, there's a cover that goes over it. Well, the thermometers you can get, but you can't get the cover that goes over it.
Okay, I think switching gears, there was a question, Dr. Rue, about the spike and about your comments about the trend across the state. And are we suggesting that the spike is going to occur in August or over the summer? And how does that coincide with the reopening of the economy and summer travel season? And do we have the beds and equipment to address a spike should it occur?
Yeah, so we look at this literally daily as far as planning for the surge, and I think the answer ultimately depends on where you are. And if there's one thing we would emphasize as a part of this, it is a very local dynamic, and so depending on the county, you got a different answer. So if you're asking about Luzerne, Lackawanna, the spike probably is happening now, or may have even happened last week. We may be just at the tail end and starting to decline. But that's different than if you're asking, well, what about Mifflin County or Juniata County, where it may very well be that that peak doesn't happen until August or some other summer month. I think that's the dynamic, and the good news here is that all of our projections suggest that that peak is lower than what we had originally been seeing. A few weeks ago, we projected that those peaks would be substantially higher and sooner. It looks like we've done a good job as a society, at least flattening the curve for now, with those peaks coming later. But we gotta be really careful, because it gets back to our discussion around the how. We can reopen in a very phased, thoughtful manner, but if people stop paying attention to the how, and if people stop paying close attention to the masking, the distancing, all of those efforts, I think all bets are off and the projections will change right away. A lot of this depends on human behavior, and so that's why we track it so carefully, and also why we plan for our capacity and our resources at the same time, because we know that things can change very quickly. And it's also why we're getting out with information both to our employees and to our communities, because so much depends on how we all behave as a society. It's also a good illustration. We're getting out and partnering with the nursing homes, even though those aren't sites that we own and operate. But we know that if we can do whatever we can from a prevention standpoint there, then we're all going to be benefited. I think this past weekend, there was a lot of good weather across our various areas. We heard a lot of accounts of gatherings that, frankly, to me, are very concerning. Big gatherings of people deciding, oh, it's great weather, things are loosening up, I could have a barbecue and invite 35 people. That's the kind of thing that's going to spike us and land us right back to where we were. And so when we talk about reopening, I think there's a thoughtful and safe way to do that. Hosting the backyard barbecue of 40 people right now is not the thoughtful way to do that. And that's what we've been trying to re-emphasize with everybody.
Great. Thanks, Dr. Rue. Dr. Hartle, we had a question about employees, the safety of employees wearing masks if they have an underlying health issue like asthma. Is there any concern with wearing a mask over a long period of time?
I think, first of all, internally, I'm not aware that we've had issues, although we have made some accommodations for some of our employees, et cetera. From their perspective as employers, it really is a matter of giving a try with an employee, et cetera, recognizing that there may be some employees that can't tolerate it and making that adjustment or accommodation for them done.
Great, thanks. We had a question about testing and turnaround times. How quickly are we turning around results on our tests?
Yeah, so we have two different type of assays right now. We have one which is a rapid assay that actually our turnaround time from the time that it's collected at one of our sites to the actual result is about 1.5 hours, 1 hour within the lab itself. Our other testing, which we call PCR testing, in general, our average turnaround time is no longer than 10 hours. So we can get results back on an individual that's been tested within a half a day.
There are a lot of sites that are doing testing. I think this is one of the big advantages, and maybe it's worth explaining a little bit. But when we do the test, because we're able to do it on site, it's a matter of hours until we get the result versus a matter of days with some of these other testing sites. The other big advantage, though, is for our patients in particular, having the test done at our sites means that the results are embedded into the same electronic medical record that the rest of their care is on, which means that when their primary care physician or their other physician is looking at that electronic medical record, there is a record of exactly what is going on and what the treatment and what the advice was, what advice was given when, and how are they progressing? Are they getting better? Are they getting worse? That integration becomes absolutely critical, because we have seen patients come to our emergency room, tested somewhere else, told that they're positive, but don't remember exactly what date they got tested. So it's impossible to then match up, well, what stage of the disease might they be at? That fragmentation ends up leading to one, suboptimal care or not as integrated of care, and two, higher cost of care if you're an employer, because that person's now potentially having redundant steps or a lot of spinning of wheels while you try to figure out the timing. We all think that patients kind of walk in with the information that's stamped on their forehead. I was tested at 4 p.m. on May 3rd. That's not how they come in. Maybe this is my bias as an emergency room physician. They come in and say, hey, I was told I was positive. Were you tested at one of our sites? No, I was tested somewhere else. It was some drive-through thing. When did you get tested? Gosh, was that last Thursday or was it 2 weeks ago Thursday? I lose count. That's what the real world plays out as. And so that value of the integration is absolutely critical, especially for a time like this.
Well, I'm sorry, Allison. You're sort of touching on another question we received. If I'm tested negative on one day, could I potentially test positive the next day?
Yes, you could. And that's part of the reason why we stay to the CDC guidelines. We're only testing individuals who are symptomatic, because you could get a test on an asymptomatic individual. And one of the concerns with that is it comes back negative a day or two later or whatever. They start to feel some symptoms of runny nose, et cetera. And I think, well, wait a minute, I already had a COVID test, so I'm fine. This must just be allergies. And they could very well still have COVID. So we have conformed and remained diligent about our testing, except for, as Dr. Wu pointed out earlier on in that clarification, there are a select subgroup of individuals that we are testing if they're asymptomatic, particularly those individuals that have been in the hospital or they're going back to the skilled nursing facility, or the labor and delivery mother that's coming in for potential delivery of her child. So there's a select subgroup that we're testing on asymptomatic, but in general, we're conforming to the CDC guidelines. And actually, those are within the expanded CDC guidelines. So
Allison, you were going to say something.
Yeah, I just wanted to build off of what you mentioned, Dr. Rue, with the benefit of continuity of care with having the testing done. In addition, it also, by having it done, triggers a lot of proactive outreach that happens. So you don't have to then wait or take your information to take it to somebody to get something done. There's going to be a lot of proactive processes that start, including a reach out to get surveillance and talk through next steps, as well as contact tracing and a lot of other things that happen as well.
So we're down to the last couple of minutes. I want to squeeze in one more business related question that's very practical. How do they social distance when their hallways in their workspace are not 6 feet wide and people passing casually? Any guidance or anything we can comment on that might be addressed even in the toolkit?
Yeah, absolutely. And I think that's where it comes down to really looking at each individual location and working through that with them. There's opportunities to, in some locations, do one-way type of patterns, where if there's a circle and you can have people at least all going the same direction, you limit that crossing of paths. We do understand and appreciate that it's not always going to be able to be 6 feet, but in as much as people can, and we will certainly work with them to help identify where those opportunities are, making sure, especially in lunch rooms, that people are maintaining and that the tables are positioned appropriately, or staggering those lunch breaks. There's really creative things that you can do to try and keep that 6 feet distance, and we're happy to work with folks on that individually. Again, it depends a lot on the layout of their facility.
I think the other aspect of it is their own personal hygiene. So hand washing, And, not, and if they're wearing a mask, fine, but not touching their face, et cetera, are keys. And I think those components are things that they need to take responsibility for, but hand washing is a huge factor.
That's terrific. Thank you. Great questions. We had way more questions than we could address live here today, but we will answer them, and they will be part of the packet that we will send out through your local chambers, as well as the toolkit. We'll provide a link through your local chambers to the toolkit that Allison referenced. So we want to thank you for all the questions. Thank you for your time today. And we especially want to thank the local business organizations from across Pennsylvania who partnered with us to bring this important information in this event to you. Our aim today was to answer your questions and help support a safe reopening of our businesses and the communities that we all live in and love so well. So we hope you found it helpful and welcome your feedback. Thanks again for joining us, and please be safe.